This is video 2 of the SRPC COVID curriculum. This video is going to talk about a setup to provide low-flow CPAP. In this video, we're going to talk about the benefits of the setup, the anatomy of the setup, the indications for its use, key issues in troubleshooting, and modifications that you can make to the setup. So the primary benefits of this setup are to provide low-flow positive pressure, which avoids the high amount of volume flow that concerns us regarding other methods of positive pressure, filtered exhalation, and hands-free pre-oxygenation or apneic oxygenation with positive pressure. So the anatomy of the setup will break into two parts, the proximal portion and the distal portion. The proximal portion is unchanged from your regular setup. You have your reservoir bags and key valves. When your patient inhales, they'll be accessing the 100% FiO2 from the reservoir bag. Your patient needs to be able to generate sufficient negative pressure to overcome these two valves. You should see slight fluctuation in the reservoir bag if they're accessing the O2. If they aren't, you'll know pretty quickly because they won't be able to breathe. The distal portion of the setup is the part that has been changed the most. This portion must have a PEEP valve, a viral filter, and a source of oxygen. When the patient exhales, this system becomes a closed system as the second valve closes. This PEEP valve is essentially a pressure-based valve that only allows gas to escape past a certain pressure in the system. Most PEEP valves go from 5 to 20. When your patient is awake and spontaneously breathing, the patient exhalation powers this valve. There's no positive pressure provided when the patient inhales. This is why you need an additional source of distal oxygen. That allows for continuous pressure throughout the respiratory cycle and allows for apneic oxygenation, which we'll talk about later. So the primary indications for use of this setup are for pre-oxygenation once you've decided to intubate the patient, and when the patient is apneic, as this provides continuous oxygenation, often without the need to actually bag mask ventilate. Now, there are a few key issues in troubleshooting that you may need to think about when using this setup. This is a video of AIM showing the setup used for apneic oxygenation. You can see here that the continuous positive pressure allows for the recruitment and oxygenation of the lung. There are two things that are crucial to facilitating this. You need a tight seal and an open airway. That means you'll need to jaw thrust the patient when they become apneic. If you need to troubleshoot the seal, for example, if your patient has a beard, you can think about using muco around the edges of the mask seal, or you can actually use a large tegaderm with a hole cut into it for the airway to allow you to develop and maintain a tight seal. While you may think about using an oropharyngeal airway for this, in COVID, its use is controversial because if your patient is not completely paralyzed, they may cough when you try and insert the OPA. This is less of an issue for reoxygenation between intubation attempts if needed. Remember that with any CPAP, if your patient is awake, you will need an anxiolytic. And finally, you'll need to speak to your referral center regarding whether or not they'll accept a patient with this setup. Many will consider this an aerosolizing setup. In addition, the setup requires two sources of oxygen, which may pose a logistical issue for transport. If you need to use an O2 tank as your second source of oxygen in your department, it's a good idea to take note of how much oxygen your tanks actually hold. This will give you an idea of how long you have using this setup. Now, there are a few ways to modify this setup based upon what you have in your department. You have leeway to change the amount of PEEP that you deliver. However, keep in mind that most lower esophageal sphincters will open at around 20 centimeters of water. Most people are recommending not going much over 10. You can add end-tidal CO2 or inline capnography to your setup to allow for visual determination of adequate ventilation and a mask seal. This will give you real-time feedback and helps to mitigate the issue with pulse ox lag that we'll talk about in a following video. While you can use a regular cuff seal mask for this, you might also think about using a non-invasive positive pressure mask because this allows you a largely hands-free setup. You may need to add an elbow adapter or an extension piece to ensure that your system remains closed if you do use these masks. This will allow the setup to be less cumbersome, and you might be able to rest it on the hospital bed or on the hospital tray. Conversely, a cuff seal mask allows for an easier jaw thrust and more control over the seal. If you don't have access to a T-piece as seen in this photo, you can actually just put nasal prongs under the mask. As long as you can obtain a seal, it's enough. It doesn't matter where the O2 comes in as long as it's distal to that second valve. Experts are recommending anywhere between 6 to 10 liters to the distal O2 source and 15 liters to the BVM. So to recap this setup, the primary indications for its use are for pre-oxygenation or apneic oxygenation during your intubation attempt. The key parts of this setup are a PEEP valve, a viral filter, and a distal oxygen source. The major benefits are potentially hands-free use and as a low-flow way to deliver CPAP. It also allows for safe apneic oxygenation, often without the need to bag mask ventilate the patient. Keep in mind that for this to work, you need a tight seal and an open airway. This has been part 2 of the SRPC COVID curriculum. Part 3 is next, where we'll talk about the nuances of COVID-19 intubation.